I mean, because a lot of men, they'll start TRT, they'll be on the treatment, their erections aren't as good, and they say, well, I thought the testosterone was going to fix it. And I tried the Viagra before when I had low testosterone, but I don't want to try that again because it didn't work.
When they have a heart attack, LDL is high, and a low LDL is much more protective than a super high HDL. We prefer 99 LDL rather than 51 HDL. It's more protective.
And there's another drug called Insulin, which you take it once or twice a year, and it blocks the gene for making PCSK9, as if you're one of those people that had this mutation. So men on testosterone replacement usually are having certain symptoms. One of the big ones is I can't keep or maintain or have an erection. And many times it can be due to testosterone, but maybe not always. And we're going to talk to Dr. George, Dr. T, about why that might be the case and what you can do possibly to have a stronger erection. So, all right, we were talking about earlier about erections. I've gone to Dr. Morgenthaler lecture. You've also seen some of those lectures. You've also seen in practice what happens to patients. Many of the times they're excited, they're complaining about low libido, but also poor erections. But the two aren't always tied.
So the professor mentioned that in order to have the perfect sex, you need stimulation of three things. First of all, you need the urge and the feeling to have sex, which is something cerebral from the brain, because testosterone is a cerebral hormone, and gives you the instinct to have sex. So we need hormonal levels.
The dopamine drive as well, that's triggered by
but we need
testosterone.
Hormonal levels, about 50%, I would say. Then we need the blood flow, which is a matter of the nitric oxide that testosterone provides, but also the 5-phosphodiesterase inhibitors. Their job is to direct the blood to the penis, but avoid from draining back. Okay?
Right, so you don't get the venous leakage.
Yes, exactly. So you need the blood to remain to the penis. And then we have the nerves in the pelvic plexus that usually are messed up and destroyed right after radical prostatectomy. And usually men after prostatectomy, because of metastatic prostate cancer, have problem with erection due to nerve damage, okay? So if one of these parameters in the chain is broken, then you cannot have the perfect intercourse, of course. But usually young men do not have a problem with the blood flow. This is something you see to older men with insulin resistance, cholesterol, plaques,
right?
All right? And usually young men have a good blood flow. It's rarely
psychosomatic. When they can't get an erection,
it could be stressed out. Could be elevated prolactin also, which is inhibitory to the testosterone. Now, older men have both low testosterone and poor blood supply. Okay, so it's very. How
old do you think it starts?
Which one?
In men? I mean, I've seen as around 40, 35. You can have this.
Yes, if you're a smoker, also you damage your endothelium. All right, so I would say around 40, when the andropause also hits, you have a problem with the blood flow. And sadly, I've seen very young men in the 20s or 30s that are taking Viagra, Cialis, Levitra, in order to have a good sex, but it doesn't work well if you have low testosterone levels.
Yeah, that's
below 500, let's say. You need at least 500, mid-range of 1,000, in order to have some decent erection. And what I call erection is, what I call a good sex drive is to have a good response to the stimulus of your sexual partner.
Yeah.
All right? It doesn't mean how many orgasms you have a day.
Right.
But if you respond well to that particular stimulus, that moment.
And if you're not, then...
And if you're not, something goes wrong. Either your testosterone is low, prolactin is high, perhaps SHBG is high as well, free testosterone is low, or you want to have sex, but something wrong going with the blood flow.
Yeah.
All right. Or now the nerve damage, I've said before that it comes after surgery, post-surgery trauma.
Right. And that's really sometimes hard to fix. I mean, because a lot of men, they'll start TRT, they'll be on the treatment, and they'll say, I might have an issue with the erections aren't as good. And they said, well, I thought the testosterone was going to fix it. And I tried the Viagra before when I had low testosterone, but I don't want to try that again because it didn't work. But like you said,
the combination is, it works synergistically.
Exactly, and that's what we have to tell the patient, because many times they've got in their head it didn't work, but synergistically you have that threshold of testosterone in which Viagra works.
So well, Morgenthaler describes, if you smell, if you see, so the sensations drive the instinct of having sex, because testosterone works in the brain, apparently, Well,
let's talk about the other area. You mentioned prolactin. Okay, prolactin is a big killer of erections and desire. And
even higher than 20.
And when prolactin goes up, dopamine goes down. This is what happens after an ejaculation. But men who have prolactinomas or even moderate levels of prolactin are still suffering
I see
from
prolactin
this.
higher than 30, and then you need a steady level of cabergoline in order to throw in once or twice a week
to keep people in the mood and improve. And everything works synergistically. Then the tadalafil or Viagra or PD5 inhibitor plus testosterone.
I think AIs kill the erection. If you abuse AIs, your lack of estrogen, estrogen is very is something very
aromatase inhibitors.
Aromatase inhibitors, yeah.
But also,
valuable for erection.
There was a paper, and some say it's in a small context, you have to put it in context, that venous leakage was caused by the absolute amount of estradiol.
I've heard that before also, yes. And if estrogen is too high, non-proportional with the testosterone, then you don't have erection that lasts.
Yeah, that's the venous leakage. And I think in the study it was the absolute, so that meaning the total amount of estradiol after it got over a certain threshold, that's when that was more likely to happen.
But you have a testosterone of 1300. It's more likely to have estradiol of 90, for instance.
Yeah,
it's proportional.
They're going to go up in tandem.
So they freak out because of higher E2, but they don't freak out because of super high testosterone. This should be proportional eventually.
Yeah, and sometimes, maybe having the testosterone a bit lower, then you have lower estradiol, you'll probably get better erection function. Some guys will report.
We've seen from bodybuilding, by killing estrogens to look drier,
that's
and
not
with
good.
lack of sex drive.
That's absolutely true. And adding.
So it's not a matter of androgens, totally the sex drive.
No, and estradiol is very
important. Come into play.
We said on previous videos how important the estradiol is in driving the libido, and when it gets low, you have no desire.
As women need a little bit of androgens and testosterone to have a good sex drive, we also need a little bit of the female hormone.
Yeah, absolutely. Actually, my latest blood test, my testosterone was about 14 nanomoles per liter. My brother's was 43, and he's on no testosterone at all. He's naturally produced.
Super high SHBG.
So about 70. So his free was like 0. I hope he doesn't mind me saying, like 0.9 or 0.8. So it's a good amount. But his estradiol was like bang on 112 picomolar per liter.
Your brother's?
Yeah, 112. Mine, I think my SHBG was a little bit lower, on 30-ish. And I think my estradiol came back around 222. And on the high sensitivity LC mass spec test, it came back around 190 picomolar per liter. So there is a difference between LC mass spec and the normal
So a 40
assay.
nanomole, how much E2 you have?
What's that?
40 nanomole of testosterone, how much is the E2?
E2 was 190.
A little bit off.
A little bit. It's kind of so, but that's
without AI.
But that's no AI. That's on that's on daily testosterone propionate, and that was.
It doesn't aromatize eventually.
It does aromatize.
It's like the cream.
It does slightly build up over time.
A little bit, yeah. If you do it every other day, it will not.
Yeah. I also though there's a little bit of HCG.
Have you noticed the cream if it doesn't spike like propionate?
Creams are sometimes harder to manage as well. Creams can go up a bit as well on some patients. I've also seen when I first started the testosterone propionate, my total testosterone was around in the 30s on the next morning when I tested.
Just before the shot.
Yeah. But when you add HCG, I forgot to mention, when you add HCG...
HCG increases estrogen indirectly.
And also the bumps up the total a little bit too.
Yeah.
And then I want to talk about HCG and libido and erections, because some men report...
It improves the sex drive.
Improves the sex drive. And so, there's some studies out there now, I don't know if I shared this with you, for Parkinson's, that hCG may actually protect the dopamine neurons. This is a Chinese study that they found that by improving
Parkinson's, they'll take L-dopa.
Exactly, but that still drives libido and dopamine agonists. When you have prolactin and you bring it down, you're raising the agonism of the dopamine or dopamine receptors. People feel much better libido. So the hCG is more than just a fertility like we talked about in the last video. The hCG
Makes you feel better.
Makes you feel better, and I think that's because of the dopamine. And that's where the Parkinson's. That's where the Parkinson's comes in. And I think some of those people who will talk about they give hCG and they're full of anxiety and they can't handle there's too much going on.
Jay Campbell said that he gives him acne. He breaks out with hCG.
Well, okay, because you're getting more testosterone, more estradiol, everything's being ramped up. But there are other guys who will also report feeling a lot more anxious. Some of them, right? It's rare. Some guys will say because it feels a bit weird, a bit different. And I think anytime you have this fluctuation in the neurotransmitters, you can feel a bit off and you can feel a bit of anxiety. So overall though, if you can get the dopamine protected, the dopamine neurons protected, you should have a better libido, your mood should be better. I know you felt that way, I felt that way. Some of our doctors that have prescribed for patients or have been prescribed it feel that hCG can make a big difference for the mood, not just the libido. So I think this is a new way to look at.
Of course, hCG increases steroidogenesis and kicks the cascade from cholesterol to pregnenolone to progesterone and then eventually to testosterone, DHEA.
But do you think it does it enough? Or even Dr. Mark Gordon will talk about, he's a big fan of allopregnenolone, one of the other neurosteroids of being neuroprotective, which is why I think as we get older.
When you take testosterone, you cut off the cascade.
That's true.
The endogenous one.
Yeah. And then you have to add in DHEA and pregnenolone.
Yes.
Do you take those?
All year round.
All year round, yeah. Well, yeah.
100 milligrams of pregnenolone, 50 a.m., 50 p.m. for my memory.
Okay.
And DHEA 25 a.m., 25 p.m. Acquitmesterolone for my liver and for my HDL and for my hair. I was taking mesterolone at least 1 decade straight. Okay. Well, my HDL even with mesterolone was 45, but now I want to keep it even higher and minimize my liver enzymes.
Were they high?
Well, about 50.
Okay.
I guess from the statin or the overtraining.
Okay, yeah, probably statin.
All right. Yeah. I'm taking all 5 milligrams of rovastatin.
Okay. That's another controversial, not controversial.
Well, I have a plaque over here that I want to keep it stable.
Yeah.
All right. I think it's from the steroid abuse because I never smoked in my life. I'm eating super clean.
Yeah.
So I want to stabilize it and not detach. All right.
And you're lucky you said you have low normal LP-little-a.
LPA, it's borderline, it's around 30. Well, I take my niacin on my cholesterol formula.
Okay.
But of course, you're taking Repatha, that lowers it.
Yeah, I do Repatha. So I said to my cardiologist, I'll never take a statin again, because I had taken it in the past and I didn't do well with it. And but I said, I will do Repatha.
Ezetimibe,
yeah.
That lowers cholesterol absorption in the intestine. Yeah. But it's not an inflammatory like statin. Statin can stabilize the plaque, while Zetia lowers the absorption, something different.
And Repatha inhibits the PSCK9.
Repatha doesn't work in the liver. You don't have a liver strain.
No, Repatha increases the amount of LDL receptors in the liver, so that
but you don't have the liver strain as with statin.
No,
the muscle strain.
No, I have no muscles. I know it works much more closely. And the people who have low PCSK9 gene, or low output of this, and there's another drug called Insulin, which you take it once or twice a year, and it blocks the gene from making PCSK9, as if you're one of those people that had this mutation. So I think, but there are a group of people that say, no, LDL, let it go high as possible. But if you have
people that get a heart attack, they always have a 3-digit LPA. I'm talking about 150 or more. This is something classic the cardiologists say.
Oh, LPA.
When they have a heart attack, LDL is high.
LDL
and ApoB.
Yeah.
Okay, this is standard.
Yeah.
And a low LDL is much more protective than a super high HDL. We prefer 99 LDL rather than 51 HDL. It's more protective because the LDL clogs.
Yeah, we found that out. The studies about HDL in early noughties.
Super high HDL is not that good.
No, there's a cohort of Danish patients that had super high HDL, and they had blocked arteries.
And you know, super high HDL usually comes with higher cholesterol and higher LDL as well.
But what about those people who say, and I know that it's a U-shaped curve, isn't it? Where, but people say, oh, as you get older, having low LDL is not good for the brain.
Yeah, because they develop dementia, or Alzheimer's. Well, my grandma used to have around 200 total cholesterol.
The one that lived 107.
She never had statins, of course. She was eating steak every single week, yolks, all right? Of course, a Mediterranean diet, but no, she was not a freak about the cholesterol.
She just got on with it, But you're right, if you're going to stabilize something, and I used to laugh. I used to say, oh, the
cholesterol is valuable. The point is the oxidation of cholesterol that comes out of simple carbs and refined sugars, all right? And insulin resistance is the bad scenario.
Yeah, well,
so you shouldn't mix white bread with steak or bacon, okay?
Your salad
or
and
sugars.
Steak, yeah.
So if you want to have saturated fats, of course, skip the trans fat, but saturated fat comes with low carb diet.
Yeah, so it's more than just, I mean, right now we drill down.
Low A1C.
Yeah, but we drill down, right, that's my point. We've drilled down on the cholesterol, but really what we're saying is that's one part of it.
And of course, lack of cholesterol lowers the testosterone. Statins lower the testosterone, okay? That's why I'm telling them when you take the protocol, don't use the statin.
Because
keep your cholesterol high.
Because you're depending on your own testosterone if you're using a boosting protocol.
Yes.
So that makes sense. But for everyone else who's full on TRT, you want to do the things that are more, I guess, cardioprotective for your health. So lowering inflammation, lowering HbA1c.
Well, apparently testosterone lowers LDL throughout the oxidation of visceral fat. When you have less belly fat, the LDL
less visceral fat,
Yes, and the A1C also. That's why testosterone eventually is protective of the heart through improving the labs, the lipids and the A1C.
And if you can improve your metabolic condition, then you should hopefully improve your erections. And it's, and then that makes everyone
lower A1C improves the blood flow.
It improves blood flow, and it makes you happy. Speaking of making you happy, why not consider subscribing to our channel? It's one of the things we work really hard and it'll make us really happy, and we'd really appreciate if you could subscribe to Balance My Hormones, our channel. There's no commitment, you just subscribe. We put a lot of time and effort into the videos to give you some of the latest information, different podcasts and different small shorts. So again, I really appreciate you for watching, and why don't you consider subscribing. Anyway, back to improving the erections, making everyone happy. What else can you do?
Some people have a claim of taking citrulline with arginine together. Arginine eventually is broken down in the stomach. Citrulline is a precursor. So they use, let's say, several grams per day in order to improve the vasodilation, the nitric oxide, which is the basis of the blood flow. And actually, some speculate that if you create a plaque, it's lack of nitric oxide. So the more oxygenation you have,
then the less.
Bettini supports this. So that's why older men develop plaques, and not just plaques, but also erythrocytosis, because there's less oxygen supply to the blood vessels.
And the blood vessels feel a bit
starved out. And the young people that abuse steroids don't develop that much erythrocytosis as older men, or even people that are using just 100 milligrams in TRT in their 40s.
What do you think about, and we did a recent video, just me talking head video, about things to do to improve libido and erections, but one of the other areas, I think Dr. Spettini mentioned it, is SAMe, right?
What about it?
Did you know it's actually quite effective at improving mood? Dopamine.
I think SAM was used in order to take off the mercury in the brain.
Well, it detoxifies the liver, but I've read that it also may help your neurotransmitters, like dopamine.
What do you find as a supplement?
Yeah, well, yeah. In fact, after the video we did with Dr. Spettini, I was taking some SAMe for a while. And I think it does give you a little bit of an uplift in mood. And I had read in, I think the Carlat report, one of the psychiatry reports, that SAMe might actually be a good mood booster that boosts all three neurotransmitters, dopamine, serotonin, and and norepinephrine. So my thought is, perhaps this might be one that can also boost libido and indirectly improve your erections. I don't know if you've come across that other than using it to...
No, there's also GABA. If you take GABA before night.
But that kind of anti-anxiety, the
GABA?
Yeah. So I want to talk about that. I took L-glycine. Have you ever taken L-glycine to help you sleep?
Yes.
Do you take it all the time?
No.
Okay.
Just before it's in the formula that I'm taking.
Okay, I took it for a while through the month of May, and I just abruptly stopped. Well, maybe I lowered the dose by like 1,000 milligrams.
Did it work to sleep?
Made me feel very calm, but then eventually I started feeling almost this depersonalized syndrome where I felt like I was outside of my body. Everything felt a bit numb, because that's what it does. It kind of numbs things down, stops the anxiety. But I actually ended up having almost a rebound effect, almost a mini withdrawal when I stopped it. So I could sleep, but there was a few nights of just feeling a little bit anxious, a little bit on edge. So I don't know if people out there have had that experience with L-glycine. I didn't find it helped or hurt my erections, and it may have dulled. I think it increased my time. It took it longer to ejaculate than
Really?
normal. Yeah, with that.
Like prolactin, huh?
It almost that kind of effect where it took longer. Yeah. So I don't know if it raised prolactin, but
Elevated prolactin causes inhibition of the
well, I'm
ejaculation.
one of this also caused it because it lowered sympathetic tone so much by increasing the GABA. So, but what it does do, L-glycine, it works on something called NMDA receptor, which is one of these other neurotransmitters that there's some new antidepressants that work on that. So I think in the next video we'll talk about antidepressants versus TRT. But anyway, for now, just get back to the erections and then we'll wrap up. So I suppose the takeaway from what we're talking about is you need to have improved insulin sensitivity, right? You want to improve the health of your blood vessels. TRT.
Homocysteine also. Elevated homocysteine predicts a bioendothelium and leads to clog and thrombosis, deep venous thrombosis and pulmonary embolism. So keep homocysteine low, below 10, single digit. Yeah.
The cholesterol and the blood vessels and keeping that all healthy.
Low A1C, below 5%.
I mean, that's what I did with Patha, because I wanted to, improve the health of my blood vessels so I could get better erections. Also be aware that the testosterone there's a threshold for how much testosterone you need for the other PDE5 inhibitors like Viagra and Cialis to work.
Yeah, I mean, Borgitalis says over 250 milligrams, you don't assimilate more because you saturate the receptors. So that comes contradictory with what bodybuilders are using, up to 1 gram or 2 grams.
Yeah, I mean, I know you've
But he speaks about the sex drive or the muscle growth.
Right, well, for muscle growth, though, the receptors upregulate, don't they? So the more testosterone that you have in the muscles, that they don't down-regulate, they don't downgrade, but there is a saturation. But I think same thing for hair loss. There's a saturation point in which once that process is started,
the receptors are upregulated when you cut off testosterone. They're searching the space for more testosterone. You saturated them, and then you deprive them of testosterone. So they are upregulated when you cut off the testosterone. Because if you feed all the time with testosterone, then they cannot get more because they're filled up. So they give a higher dose of testosterone to saturate the receptors in testosterone cancer, but then they deprive of testosterone.
You're talking about what's it called? Bimodal therapy. What's it? Not BiPAP? Yeah, I know what you're talking about for prostate cancer.
Yes, during the prostate cancer.
Yeah,
they give a super high dose of testosterone to fill it up, and then you deprive of testosterone, and then they're upregulated afterwards, the receptors, because they want more of the something of the compound, But Mogitalis said that after 250, you cannot get more. So,
right, that's a saturation point.
Yes.
So you're not going to drive the prostate cancer off to 250, because once the prostate cancer androgen receptor has been filled, beyond that you're not going to get doubling or tripling of the prostate cancer. Yeah, and I think that's becoming more and more recognized. Like I said, I went to his lecture. Takeaways for erectile dysfunction is quite multifaceted. You've got everything from, you need a minimum threshold of testosterone, you need to have a good plumbing, basically the blood vessels need to be relatively clean and clear, and you have to have low inflammation in the body. There are other factors that may come into play with whether or not you can maintain an erection.
Also.
C-reactive protein for inflammation. I mean, there are tools. Let's wrap up with, there are tools that you can use. We talked about PDE5 inhibitors. I think in the US it's quite common to use injections, intracavernosal injections of L-citrulline, which many men aren't really keen on injecting. And there's a book written by a UK doctor, Geoffrey Hackett, who talks about, I think it's called Just a Little Prick, the stories of a dick clinic doctor or erectile dysfunction doctor. But that's something that can work, when you want to have it, but that's a bit inconvenient. But so what you can do to prevent it is good lifestyle, good diet, and having optimal testosterone levels and lowering your overall inflammation so that you don't have to depend on these other modalities. If you're having issues with your erections, let us know in the comments below. Let us know what's worked for you, what hasn't worked for you. Hopefully you found this video informational and helpful. Please don't forget to subscribe and like, and we'll see you next time. To your health, to your wellness, and to your happy erections.